Hello friends and welcome. My name is Lori Beth. I'm a doctor of physical therapy. Today I have a lovely patient who has really obviously injured his arm. We are going to be putting him through a series of special tests to see if he possibly has an anterior or posterior shoulder instability taking place. We have already asked him a series of questions. We have a few indicators that an instability is taking place, but we're not sure if it's a posterior instability or an anterior instability. Now we're going to do an assessment, putting him through a very common shoulder instability test in the anterior and posterior direction to see which direction his instability is coming from. Remember, if you are in a clinical setting, to ensure that your safety and your patient's safety comes first, you're going to respect their boundaries, what makes them feel uncomfortable. In a clinical setting, you 100% want to make sure you're positioning yourself and your patient in a way that is very respectful. You do want to be doing an accurate assessment, but not at the cost of your integrity or your patient's. The patient is sitting unsupported, the back is unsupported, and the examiner is going to stabilize the shoulder over the clavicle and the scapula. Then they're going to be firmly grabbing the shoulder and trying to displace the humerus forward and backward. You need to keep your arm still. The patient has a lot of mass. You have to very firmly grab the humerus. It is very difficult to stabilize your scapula and clavicle. I'm having to really dig in there. You're not going to be moving this. You're just sitting passively. Do not move a muscle. I am going to be stabilizing your shoulder, and then I will be moving your arm. You don't need to move it. I will do that for you. Then I'm going to be grabbing the head of the humerus and trying to displace the head of the humerus in the glenoid cavity forward. I can also test backwards. A little displacement is normal. This is not excessive. You can also test this in supine. Firmly grasping, I have the thumb stabilizing at the scapula and my finger stabilizing the clavicle, grabbing the head of the humerus and trying to displace it. Now, because only about a quarter of the humerus sits in the glenoid cavity at a time, a little bit of displacement is normal. You just want to make sure that not too much of the humeral head is coming out of the glenoid cavity.
My arm be up like this?
Resting on your body, yeah, or resting on the table. Because you have extra mass, it is easier to actually stabilize the shoulder because now the actual test table is going to be providing some stabilization as well. Are you completely relaxed?
I think so.
This is where your shoulder's relaxed. Quite a bit off the table to begin with. Very tight in the chest, trying to stabilize. You're just so off the mat. I don't really want to be overly pushing aggressively to where you're prodding the patient uncomfortably. It can be difficult to get in to grab the humerus to move it forward and back. But if a patient has an abnormality and it's overly loose and moving very far outside of what would be considered normal, you'd be able to tell if it was an abnormal finding, especially if there's a dislocation. It can be beneficial to use a Colton-Warren wedge to help in stabilizing the scapula. Maybe lift up just a touch, there you go, and that's going to help me stabilize. When performing the load and shift test, whether you're moving in the anterior or posterior direction, normal translation is about 25%. Grade 1 is when there's a feeling of the humeral head riding into the glenoid rim, which is normal, but if it starts to go excessively more than about 25% displacement, this is when you're looking at a grade 1. A grade 2 is when there is a feeling of the humeral head sliding over the rim of the glenoid cavity, but often this will still spontaneously reduce as you translate the humerus back towards the middle of the joint. Grade 3 is a feeling of the humeral head riding out of the rim, but it will not be able to relocate. It will remain dislocated. And all of this then would probably be very uncomfortable to the patient. Really trying to make sure you stabilize. That is so important because when we're watching and doing assessments, even if you see something like on YouTube or in a textbook, often what we see in the actual clinical setting is different than what you see in a textbook or on a YouTube video in school. And on YouTube, they're often presenting the best case scenario, but most of the time, patients are going to have pain, they're going to be guarding, they're going to carry a ton of muscle, and automatically it becomes a lot more difficult. You do want to be able to determine, is it less than 25% displacement, showing that it's a negative test and that it's only a normal amount of humeral head displacement, or does it start to go over the normal amount of movement where we have issues with anterior or posterior shoulder instability. If it's overly moving forward, that could indicate anterior instability. If it's overly moving in the posterior direction, that would indicate posterior instability. The next exam that we are going to be doing is called the crank test, and this is a test that's not as commonly performed in the clinical setting because so frequently patients will complain of pain and discomfort and have issues of instability or pain in the anterior part of the chest. There's so much tight musculature in this area for a lot of people, but what you're going to do is you are going to bring the arm into abduction We're gonna bend the elbow and then begin to add more external rotation, adding external rotation and stabilizing his humerus. As you externally rotate, the humeral head is going to slide anterior within the glenoid cavity and testing the anterior component of the capsule to see if there's apprehension noted by the patient, and there is no apprehension. Right.
Yes, ma'am.
If they have tight musculature, they could still have an anterior instability with too much movement taking place in the anterior direction, but often the muscles are what's keeping it stable in the glenoid cavity, and he has no issues there, even though you've got plenty of issues. When you internally rotate, you're gonna have the humerus slide posterior, which is why his shoulder starts to pop up off of the test table. In the apprehension or crank test, we are assessing anterior dislocation or anterior instability. The examiner is going to abduct the arm to 90 degrees and externally rotate the patient's shoulder slowly, placing a hand under the glenohumeral joint, acting as a fulcrum, then applying an anterior directed force to the posterior humeral head when in the test position. We're going to abduct the arm to 90 degrees and start to externally rotate, providing a counterbalance with my arm underneath his. I start to push up on his humerus with my arm underneath, acting as the fulcrum. That is the crank test. If a superior internal impingement is suspected, then we're going to also want to do a relocation test in 110 degrees and 120 degrees of abduction. In most of the tests for anterior shoulder instability, you are consistently going to be moving the arm in a very similar direction to this, because as you add the external rotation, you're consistently forcing that humeral head in the anterior direction. A lot of the anterior instability tests look like this, and a lot of the posterior tests, you're going to actually internally rotate and bring the arm across. Even though there's a host of tests for anterior subluxation or instability and posterior, they look very similar. The next test that we are going to be doing is the Rockwood stress test. In the Rockwood stress test, we're going to be performing a very similar movement. We're going to abduct the patient's shoulder. If he's complaining of left shoulder instability, often you're actually going to want to test the right shoulder first, because that's going to be your baseline. If there is no symptoms taking place in the right shoulder, when you go to move the left arm, you can compare it to how it should feel based on symptom pain-free shoulder. We've already done an assessment of that side to see how his range of motion is at 90, 110, and 120 degrees of shoulder abduction. We are going to abduct, and the patient's abducting for me. He's not supposed to do that. This should be a passive test. Again, if they're passive, their arm should consistently drop if you're not the one holding on to it. If you feel the patient actively doing the movement, you immediately, because they need to be passive for this test, need to bring their arm back to neutral. He is not relaxed. We're going to bring the shoulder up to 90 degrees of abduction, and now we're going to provide the external rotation. No issues. A little bit of tightness, but not bad. And these are all things, even though you might be assessing for a positive or negative in this test, the assessment is actually taking place throughout the entire performance, where you're watching, are they grimacing? Are they able to relax? Are they able to follow one-step commands and instructions? Even though you're actually looking for apprehension, pain, guarding, abnormal behavior on behalf of the patient, you're assessing other things as you're doing the movement. I immediately know he has fair shoulder abduction because he's initiating the movement for me instead of letting me be the one that's abducting the shoulder, which means he's actively engaging a lot of his rotator cuff muscles, to include his supraspinatus and his medial deltoid. 90, watching for any compensation to take place, any hiking at the shoulder, trying to make sure that the movement is happening through the humerus in the glenoid cavity and not from somewhere else. Now we're going to come up to 110. How you doing? 120? Very good, sir.
Thank you, ma'am.
You never played baseball? You do want to assess the non-involved side first. And if there is issues on both sides, take note of that. Ask a lot of questions to get to the root of the problem and see structurally, functionally, what's causing these issues. Is it something that can be treatable in a clinical setting? Is it something that we might need to send the patient back to an orthopedic specialist? Are they going to need surgery, etc.? But most of the time, we want to catch these things very early and manage them very early. We are now going to discuss the Rose test for anterior shoulder instability. We are now going to discuss the Rose test for anterior shoulder instability. In the Rose test for anterior instability, the patient will again be getting into the supine position. The examiner will place one hand via a clenched fist against the posterior humeral head, pushing up slightly as if in a fulcrum type of test, as we had done in the previous assessment. and pushing the arm up slightly while also extending the arm further because the patient has already extended their own arm up and behind their head. The test will be positive if there is any apprehension or pain, and a clunk or grinding sound could indicate a torn anterior labrum.
Would you mind, please? How am I supposed to go back to plan for the 10th day raise if I have to deal with this thing?
Anytime you want to help the patient get into the supine position, in part because you never know what kind of difficult subject you'll be dealing with.
That's me.
You help them down. Often they will come in with mental illnesses previously. This is not something they've acquired in your clinic. The more documentation you have, the better. The patient has been assisted into the supine position. I have already told them what I'm doing and why I'm doing in advance that will help them feel more comfortable and have more confidence in you as a therapist. Then you're going to be walking them through it step by step. Have the patient reach their arm up over their own head, as if he's going to be nearly combing his own hair, but not exactly. The patient's arm is up over his own head. Now I'm going to have my hand via a clenched fist underneath his shoulder, operating as a fulcrum to move the humeral head and the shoulder capsule into the anterior directed position. And now I'm going to add an extension force to his humeral head, really fulcruming the head of the humerus into the anterior or forward direction. No problem. Just pushing it straight down. Right? You okay?
Great.
You actually are more springy in this position than you were at 90 degrees quite a bit. I want to feel the infeel of the joint to see where the tightness or pain is coming from, if there is any. Usually you're not going to do this test unless the patient has verbalized something to make you feel like an anterior dislocation as possible. Otherwise, putting them in test positions like this could exacerbate problems if it's actually somewhere else. Your questions that you perform in your interview and assessment in the initial evaluation should guide which test you're performing. And again, if he has these issues on his left arm, you're going to want to assess the right shoulder first.
No problem.
This was the road test for anterior shoulder instability. During this assessment, part of a positive test is when the patient either verbalizes or demonstrates some sort of instability, discomfort, pain, uneasiness. They're going to be either saying something or expressing in their body language or their facial expression. Can you show me your I'm in pain face? Perfect.
It's a lot like my hoop face.
So if the patient's got a very flat effect, it could be a lot more difficult to determine if they're in pain or discomfort, but you want to be assessing that. If they're reporting of pain, maybe they even have someone with them if they do have flat effect, so that they can say, hey, they're not a very expressive person, they don't show signs of pain, but I know because of XYZ, so you can really learn your patient better. They might even poop themselves. If the room begins to stink, make sure you're assessing for a unexpected bowel movement. Ladies and gentlemen, we are discussing shoulder special tests, but I'm very familiar with my patient and I am well aware of them having issues with their back and having pain leading to discomfort in their glute, their sciatica region, and having specific instructions to minimize extension, which includes lying prone. If you're doing shoulder special tests or any type of special test for that matter, you also have to be cognizant of other complications, issues, or even patient-specific details. Patients that are possibly pregnant or obese, overweight, some test positions have to be modified in order to determine the most optimal series of tests to perform, questions to ask, and what modifications need to be taken for your specific patient. In the prone anterior instability test, you're going to want to obviously have the patient lying in prone. You want them to be comfortable laying on the test table where they can still breathe. You're not obstructing their airflow or making them in any way, shape, or form uncomfortable, but they do have to be prone. If you cannot get the patient prone comfortably or safely, then you need to skip this test and pick something else. The patient's going to be laying prone with their shoulder stabilized. It can be stabilized on the test table. You can use a Colton-Born wedge. I need that. You can use the Colton-Born wedge. Oh, I still need it. And you can use that to help stabilize the shoulder joint. This is stabilizing my shoulder at the clavicle. And then I'm going to have the arm over the side. I want to have enough to be able to provide that anteriorly directed force. I'll walk you through it. You're just going to make sure I'm stabilized here, and you're going to push the humeral head forward. Grab my humerus from the back, not from the front. You're going to grab just enough of the humerus to be able to push it in the forward direction while the Colton-Born wedge is doing the work of stabilizing the shoulder joint. You're going to push in the forward direction at the relative to the anatomical position. If I were standing forward, then forward would be this way into the ground relative to my body. I want you to push this way and stabilize up there. Okay. This is actually a fake humerus, and this is a fake scapula. Can you see my scapula and my humerus? The patient is going to be lying down. We're going to be stabilizing. This is actually the other arm though. Just for kicks, we're going to move it this way because we need this going that way, even though this is actually the front of the scapula. I'm just pointing it this way because I want you to see the glenoid rim. Technically, if it was this right scapula, you'd be coming this way. And the humeral head sits inside the glenoid cavity. This is going to be stabilized, and then you're going to be pushing anterior down, pushing the humeral head straight forward, not pulling it away from the glenoid cavity, not pulling it or playing bop it, stabilizing the scapula and pushing the humeral head in the anterior direction to see if there's any anterior instability. That's the knee, babe.
Oh dear. Oh dear.
The patient will be lying on the mat. You're going to have their shoulder joint here, and you don't have to have the wedge. The wedge is optional, but you're going to have the glenoid cavity, the shoulder pointing off the mat. So that gives you room. Their arm will be on their side, and you're then going to be pushing the humerus directly forward, stabilizing the shoulder, and you're going to be pushing the humerus directly forward relative to the anatomical position, not relative to forward in front of you, but relative to the patient's forward. If it's okay, may I slide this in here a little more?
Okay.
Relative to the patient's forward is going to be this way, stabilizing. You can even push into the mat a little bit. You're going to grab the humeral head and push forward. Use as much of your hand as you can. In the Andrews anterior shoulder instability test, the patient is going to be returning to the supine position. We are again going to abduct and externally rotate the arm. This time we are going to be pushing the humerus in the anterior direction relative to anatomical neutral. When you are treating a patient, you are describing the movements based off of the patient's anatomical position. Facing forward, arms out to the sides, and palms facing forward. Making sure the patient is comfortable, we're going to be putting a pillow of some sort underneath their head to make them comfortable. The patient's comfort is very important.
I feel comfortable.
In the Andrews anterior shoulder instability test, we are going to be abducting the shoulder further than we have previously. We're going to be abducting the shoulder 120 degrees. Then once the patient's arm is stabilized on the test table, then we're going to be providing the anterior force relative to the patient. You can use a wedge if you wish, whatever it is that makes you and the patient both comfortable, while also being able to ensure that the shoulder is stabilized and the anterior force is coming through the humerus in the glenoid cavity. Third, relax your arm, externally rotating. You can barely get down there. You're not really able to get into the test position, which is fine. I'm stabilizing, holding onto his humerus here, and now I'm going to provide an anterior force. It's a bit of a fulcrum there. It's really hard to get bringing the proximal part of the humerus forward in the anterior direction. Kind of get to where you can really see. 90 degrees of abduction, a little more, 90 degrees of external rotation, stabilizing the distal part of the arm, and then pushing in the anterior direction. You do, if possible, want the force to be perfectly upright. You can obviously change the angle of my wrist. Often textbooks will show this being perfectly oriented to be pushing anterior, but in a clinical setting that's rarely perfect. But you still want an anterior directed force through the humerus. The examiner is going to place their hand on the affected shoulder, and they're going to be putting the patient's hand in the examiner's axilla, in the examiner's armpit. This way, the patient's arm can ideally remain relaxed. The shoulder that is being tested will be abducted between 80 and 120 degrees. Then we are going to forward flex the arm 20 degrees and add a little bit of external rotation up to 30 degrees. We will then be stabilizing the patient's scapula with the opposite hand as we always do. Again, remember, this can be difficult if the patient has a lot of pain, guarding, or are they excessively non-cooperative, stinky. The examiner's thumb is going to exert a counter pressure on the patient's coracoid process. Using the arm that is holding the patient's hand, the examiner will place his or her hand around the patient's relaxed upper arm, drawing the patient's humerus in the forward direction. Anterior drawer, you're basically going to be stabilizing the shoulder and pulling the humerus forward as if it was a drawer, pulling the drawer out, but instead pulling the humerus anteriorly to assess for anterior instability of the shoulder. We are actually going to be placing the patient's arm in our armpit. That way I can use this and still have two hands free to work. I'm using my axilla to be able to stabilize the patient's arm, keep the patient relaxed, while being able to also mobilize the arm into abduction, external rotation, and then place an anterior directed force while also stabilizing the scapula. Now I'm going to be using this arm with my whoop on it to pull the humeral head in the anterior direction. I actually think it's beneficial that I'm kneeling and you would ideally have a test table that actually moves up and down, but I'm going to use my leg to actually leverage anterior as well. I'm adding rotation, that's not supposed to happen. Immediately, if I start to come this way, I'm adding more external rotation, and I don't want that. You want the movement to come completely up straight. If I put your arm a little like that, that's better, right? It's okay to have to wiggle around and figure it out. Every patient's going to be built differently, and every examiner is going to be built differently. Just use the information you get while having the rotation element in your favor. Do you discarding? Do you notice compensations? Do you use grimacing? Use all of that information in the patient's assessment examination. If I had to, I could easily get a tech or someone to come stabilize so that I could ensure that my force was coming forward. A lot of places will use belts and straps. You want all of the movement to be coming from the joint in the way that you want it to become. Approximate test for anterior shoulder instability. If it is difficult to perform proper stabilization to your patient's arm, you may want to ask for assistance or take advantage of equipment you have available to help with the stabilization process. Whether you're using a Colton-Boren wedge or pillow, anything possible. Sometimes test beds are able to be adjusted in order to help with the stabilization process, or you can ask someone to help you stabilize the shoulder to make sure the movements are being directed in the way that they are supposed to properly perform the test. We're going to do this side. Approximate test for anterior shoulder instability. The patient is in the sitting position. I'm going to use not only my arm, but also my leg to help hold the weight of his arm so that I can abduct the arm before applying an anterior directed force on the posterior aspect of his humerus. I'm actually going to use my leg to assist in the abduction of his arm so that he's not having to support the weight of his own arm into abduction. My leg is supporting his humerus so that he can be into abduction at the shoulder without having to actively elevate the shoulder. I can stabilize here, stabilizing his humerus while performing. This is actually really nice. You can use your fingers. You can really ensure that you're palpating the humeral head and pushing the humeral head into the anterior direction. It's good to see which assessments are best based off of your body mechanics and the patient's body mechanics. I'm really easily able to get in there and press on the humeral head while stabilizing his arm, and my leg's doing all the work of holding his arm up with zero effort. So I could actually do this with my whole hand, but it is a little more accurate to palpate the humeral head and push in the anterior direction for the approximate test. Make sure we're rested. I'm gonna bring the arm up, my leg to stabilize. Trying to make sure both cameras can see. Feels like I'm getting in there accurately, don't you think? This actually would be incredible, and if you wanted to do any direction, I could actually stabilize the back of his shoulder and use my hand to push in the posterior direction. It's difficult to see different angles, but again, you always want to push as perfectly posterior as you can, again, relative to the patient's anatomical position. I can push down, I can push up, down, forward, backward, but you do want to stabilize here. This test with the leg supporting the weight of his arm makes it a lot easier for me to stabilize his shoulder and push the humeral head in various directions. When performing a clinical assessment on a patient for any joint pathology, it's good to have a host of options for different special tests to find what's best for the patient's body mechanics, for their stature, for their specific condition, absolutely every single way. It's very beneficial because we have so many things to assess to get a well-rounded understanding of our patient's complaints of pain, what their symptoms are showing and pointing to in terms of their pathology, and what treatments are going to best help their recovery process. The Dugas test is a fantastic option. It is so short and sweet and simple. You're simply going to have your patient touch their opposite shoulder. You're going to have the patient touch the opposite shoulder and then try to drop their elbow towards their chest. That alone is actually bringing the head of the humerus in the anterior direction as you go to drop your elbow down relative inside the glenoid cavity. The humeral head is moving forward. Does that make sense? Do you feel that a bit? You can actually really see it pretty well too because it's a ball and socket. As the bone comes down this way, relatively the humeral head is coming forward or anterior direction. Because again, it's always based on the patient's anatomical position.
Right.
Perfect. Passively, I am going to bring his arm into the test position. We're going to internally rotate and horizontally adduct. I'm going to stabilize his arm. I'm now going to push his arm in the posterior direction towards the green wall behind him. You can do this a host of ways. You could push this way. You can also continue to put a force down through his arm this way. It's really difficult to show this one. And you're also going to want to be pushing a posterior force towards the green wall in that direction forward. Pushing him posterior. I'm going to abduct. I'm going to bring the arm into internal rotation. Internal rotation, horizontal adduction. I'm going to add more internal rotation by pushing the arm down this way. I'm actually going to stabilize there just a little bit. And then I'm going to push this posteriorly. Internal rotation here, while also pushing his humerus backwards towards his spine. Internal rotation and posterior. anterior rotation, posterior. All of the posterior instability tests, they're going to come down to the same basic positioning. When we do an anterior instability test, a lot of them are going to look like this. When we do a posterior instability test, a lot of them are going to look like this. Internal rotation and horizontal adduction to force the humeral head into the posterior direction. The patient is now in the supine test position. We are going to abduct the shoulder between 80 and 100 degrees of shoulder abduction. Then we are going to add a little bit of external rotation, 90 degrees, before we bring him into the test position. We are now assessing the posterior capsule, the posterior glenohumeral joint capsule, assessing how the humeral head is moving in the joint capsule and if there is any excessive movement there. We are first going to make sure that the patient's elbow is flexed. We're going to then abduct and externally rotate. Because we are assessing the posterior joint capsule, I am now going to provide a force in the posterior direction. Right? You feel that okay? And it is okay to ask your patient if they're feeling the movement correct. It gets them more aware of their own body mechanics and it gets them really listening to what's going on within their own body. A lot of people are not very aware of their own, where pain is coming from, especially because so often we only pay attention to pain when it's hindering us in some way. And so many people are also on pain medications. Having the patient tell you how they're feeling is hugely beneficial when doing any sort of physical assessment. Trying to make sure I'm really pushing in the posterior direction. Now we're going to add this across the chest, horizontal adduction, which is also going to push the humeral head in the posterior direction. How are you doing?
Great.
And then you can also add a posterior directed force through the humeral head that way. Now pushing the humeral head posterior via effort from my own arm. How's that? Get comfortable. Thank you, sir. Are you comfortable?
I'm comfortable.
All of the posterior shoulder instability tests are very similar in the patient's actual setup. We are again going to be getting the patient in a very similar test position, but in a push-pull test, we are going to be pushing and pulling in order to provide the posterior force into the glenoid capsule, into the patient's shoulder joint. All right, so I'm going to talk you guys through it first, and then we'll just demonstrate it. Now I am going to again assist the patient's arm into abduction, rotation, but because I'm doing a pushing and pulling movement, it's going to be kind of hard. Again, some of these are really hard to demonstrate correctly. This is going to be my pulling hand, and I'm going to be using my left hand to be my pushing arm. I'm going to pull and push posterior. I'm pushing his humeral head posterior, and I'm pulling his arm to add into that fulcrum effort to be pushing his arm into the posterior direction. As I pull here forward, I'm pushing directly backward. The push-pull test. Wonderful. I'm just going to do it this time. I think my toe is popping out of my stocks. The patient is supine with their shoulder off of the mat or the testing table. I am going to be using my hand to flex the arm between 70 and 90 degrees of flexion, and then I'm going to adduct and internally rotate the arm while pushing the humeral head in the posterior directions. I will also be palpating the anterior and posterior aspect of the shoulder joint and abducting and rotating the arm. It's going to be really tricky to make sure all of these different factors are in place, which is why it's good to use your hip if you need to rest the arm on your hip in a table that moves up and down. This is the arm in neutral position. We're going to just bring the arm a little bit forward. I'm going to now flex, adduct, and internally rotate, adduction, internal rotation. Now I also want to perform a posterior directed force through his humerus without losing the stabilization anywhere else. This one better. Let's see. Does it feel good?
Yeah, it really does.
His joint capsule is going to be so stretched out. Good. When I was in school, they wanted the force perfect. That means you would want to move your body, irrelevant of the camera, to make sure that my force arm is moving directly posterior. I can do that, but to put the camera first, I cannot do a perfect posterior force and also maintain that internal rotation. It's been a little bit of an unsuccessful day, but hopefully you were able to learn a lot about anterior and posterior shoulder instability and how to assess a patient for anterior and posterior shoulder instability. Whether you are injured, have had an injury in the past, I should not be touching my patient like that, and we will do everything in our power to help you become stronger and a better athlete. If you have a body, you are an athlete, and we want you to be functioning your absolute best. Isn't that right, sir?
Yes, ma'am.
Thank you guys so much. Have a beautiful and blessed day. Bye-bye.